you guys again. We were here on the first day of the transition series. So my background is nursing. I'm a healthcare facilitator with Toronto Network Specialist.
Too quiet, right?
Yeah.
Too quiet.
Louder. Closer to the mic.
And I'm still Lindsay, and I'm a social worker and I'm a care coordinator with the adult supportive care team at CCAC.
Can everyone hear me better? Okay, maybe I'll just take it. Okay. Is that better, people? Yeah. Okay. So to start out, we're going to go over some of the current evidence that we have in the sector, and it's from the developmental sector, that talks about aging transition from an Ontario perspective. So we'll go over that. And really why we're here is we want to know, okay, how do we help, how do we manage, what are the strategies, and how can we improve collaborating across sectors. And this morning, I think Sue and Peter really nailed it in talking about the context that we're all seeing with aging. And everyone here is aware now, especially from Sue's presentation, that people were living in institutions and they just recently closed. And I was a nursing student in the time when these agencies were, these institutions were still operating, and we didn't talk about it in curriculum. We didn't talk about it in nursing school. So people were still living and aging in institutions up until 2009. And I was struck by, especially when I was in contact with, for example, long-term care, directors of care, some of their stories about receiving clients with this historical context and not having that information. I myself received clients who were in the institutions who were aging, and there was a black hole that their medical history fell into. And not having that picture and the understanding of who the person was medically, as well as some of the trauma history that came with the person. So Pam was the director of care at Valley View Long-Term Care. When I met Pam, she gave me some really good insight into huge gaps of information in what long-term care was receiving, and some really difficult situations and even tragedies. So that really helped me because I'm coming from a different lens. The DS lens is quite different. And understanding that it's not only this historical context of aging differently in institutions, but also that there's a medical context of having disparities in care. So superimposed on top of these disparities of not having good primary care from youth comes aging. And some of the higher prevalence issues that are not high prevalence in the general population, we don't expect it because it's not our understanding in general population. So things like dental caries and dying from cardiac issues that were never identified, or obesity and diabetes. There was actually a couple of years ago, the research was saying that diabetes was not a higher prevalence in people with developmental disabilities. And now we know it is. It is a higher prevalence in people with developmental disabilities compared to general population. And conditions like epilepsy, we expected, things like dementia, and dual diagnosis. But really understanding that there are huge disparities in even the basic primary care that people with developmental disabilities are receiving currently and were receiving back when they were young, that has now a cumulative effect now that that people are aging. And what has really saved me in terms of how I approach conversations with evidence has been that I can be a knowledge user with HCARD, which is healthcare research within developmental disabilities. And they are doing really groundbreaking research looking at the Ontario population of people with developmental disabilities who are aging, and also talking about health checks and how, what does that mean for people with developmental disabilities, and how critically important it is, especially now that legislation is changing in terms of, we no longer get that annual physical as a given. Whereas in our DS legislation, we're asked that people go for annual physicals still. And our DS residential agencies are catching up with, now they're facing pushback on family health teams saying, well, we no longer do an annual physical. But there is evidence we can bring to say that that health check, and using that term instead of the annual physical, is what we do need to still support the people with developmental disabilities because of differences in presenting differently with things that would be caught for someone who didn't have a developmental disability. So how do we advocate and support this? And we talked about this on day one, really. What's the first word that would come to your mind in terms of where do we start advocating for things like health checks? Anyone want to share that? For me, it's information. It's just starting at that basic level. Is how do we gather information to be able to advocate? And usually, it's suspecting first what's the underlying medical issue that's contributing to this the whole picture, and finding that medical information. In our DS sector, we might think that we're not the ones who should be doing that. That's the health people, but we can really facilitate that piece, the information sharing about the medical and what might be a place to start if we're suspecting that there's something medical going on. And there are tools that, for example, the primary care tools that we talked about on day one, that we can collect, we can advocate for those tools. There's also the health watch tables. So with respect to transition and aging, we've used health watch tables, for example, with Down syndrome and suspecting dementia. And Rachel's here. Rachel. So Rachel has been a great advocate in the sense that so she's pushing forward with the hospital team that may not have that expertise or understanding of Down syndrome, and asking for let's rule out medical. And many of us feel that's not our expertise to ask for. But using these tools, we can bring a tool that's written for a physician to read that tool and help them to understand with someone with Down syndrome, for example, that the research is saying as early as age 40, 11% of people with Down syndrome may start being affected with dementia. And on the flip side of that is I've seen two extremes where an agency will maybe be too aware of that fact and suspect dementia a little too early. And then the threshold for thinking, okay, now we need long-term care is very low. So even a suspected diagnosis of dementia may start someone on that pathway to long-term care. Whereas you heard this morning with Peter's example that he spoke about his wife and that it was suspected that she had dementia at one point when it was PTSD. It was really trauma that was causing what was happening at that time. And I have many other examples. There was a client with anorexia, and she was actually labeled with dementia, having dementia, when it was nutritional type issues that made her present as having dementia. But then that started the pathway. Should we be thinking long-term care? And it was really obvious that she had anorexia. So that being said, we also have to be careful how we're using information and do due diligence in terms of getting the testing, advocating for the testing. And also trying to collect our own information to bring to the healthcare providers. We talked a lot about that on the first day. So has everyone seen this tool, the early detection tool, the screening tool, the antigen tool? Yeah, I've seen it, because I know Rena has had a lot of publicity about this tool, and Rena uses it they use it in a very methodical way. to collect information that is baseline, so that when there's changes, the baseline info has been already been connected, and we can look at are the changes really, are they dementia related, or are we looking at a different health issue? And this was actually a tool that helped the person who had anorexia to be identified as someone who needed help with the anorexia and didn't have dementia, although she was enabled with that diagnosis. And I would encourage people that if you have someone that is aging and you want to collect this baseline information, that this is a tool that might be helpful. And especially there's a page that talks about concurrent medical issues, because maybe we wouldn't put anorexia together with confusing the label of dementia. But if we have that listed on this tool and we brought it to the family doctor, that would be a red flag to the family doctor. Because when I saw that on the tool, the caregiver team had identified that, immediately it's a red flag to question, is it the anorexia or is it dementia? Because that will really influence the trajectory of the person's transition, their aging transition. And there's really quite, I would say, outstanding research coming from CAMH and the Age Card team on the whole, which is across Ontario, that is presenting the government with really groundbreaking stats. Like, does anyone know what I mean by 80 at 50? 80 at 50. What does that mean, 80 at 50? Yeah, exactly. So what they found from the research.
Can you repeat what they answered there?
Oh, sorry. About aging faster. So current research is showing that people are aging. They're living longer, whereas before people were living, say, into their 40s maybe. When in 1970s it was in the 40s. Now aging, living longer, a lot more complexity because of not having good primary care since youth. But not only that, they're facing barriers like age criteria for programs. So Lindsay might be able to chat a bit more about that, but there are some programs that have age criteria, such as 65, to be able to access them. And that's changing, but with barriers like that, if you have people who are aging faster and they're showing frailty, the similar type of frailty of an 80-year-old at the age of 50, and they're not able to access services until they're 65, then we have a gap, a huge gap there. Because this is what the research is showing, that the frailty indicator is that someone who is 50 years old with a developmental disability is presenting like someone who is 80 years old. And this is all on the website that's listed there. I encourage you to read it because it's got a lot of information and tools on that website about aging. The other piece that really stuck out to me was that adults are more likely, at least twice more likely than the general population, to use home care services. This is hence why we're very happy that CCAC is here. And also at least twice as likely to be admitted to long-term care. And also it was saying that adults are admitted to long-term care 25 years earlier than general population. So this is what the age card stats are showing. And visually, there was a graph on that also they used to portray these stats. So who are our partners in collaborating for aging? And Karen, who's a social worker, sorry I had to mention her, because a really key person to connect with at Community Knowledge, Karen. She said something today as well that really was communities may not be ready for aging. Communities may not be set up So residential programs, for example, are based out of a home that is in the community. And many homes are not accessible. Many homes have stairs and are not renovated to the point where it is fully accessible and portable, distinctive, and all of that. So a huge care partner, of course, is going to CCAC, going to be CCAC. And we have to be full partners in the relationship to be able to add the developmental sector lens and collaborate. And the other huge partner is unfortunately Emerge. So because we're not set up well, things happen. People fall. There are complex behaviors because people can't communicate that they're not feeling well, and the place to go is Emerge. So we do have to forge strong relationships with our Emerge departments that are near the home. Because when you call an ambulance, if it's an emergency, they're going to go the shortest distance to access emergency services. So having some relationship with the Emerge department, knowing who, for example, might be a manager or a coordinator who you can connect with, that just recognizing that they are really important partners that we need to have a relationship with. And of course, long-term care. And there are many people here. That's why it was very nerve-wracking to come up and speak, because I know I'm talking to an audience that's extremely knowledgeable. And there are people who are in the audience who should be here instead of me, from CCC, from long-term care, that can speak on this. But also recognizing, and there's a video, we don't have to watch the video, but if you can look at it, it's interesting because there's an Emerge position that really says something simple. But I just really keep stressing that healthcare providers need the information from us, from the person, the client, and from us. So our full responsibility is to try to get that information. And if we know the person is in Emerge or in hospital or receiving CCAC services, we have to work and present that information. And that's where I see sometimes my role is heavily used in trying to access good information about their medical needs. So I just wanted to stress that. And for aging, it's even more complex because there's a longer medical history. So it's even more important. And just tying in from day one and day two, there are many resources that we can use for people who are aging and need to access aging care services. And whether it's CCAC, long-term care, using partnerships with DSTO, with Griffin. We have to mention Griffin in Toronto because they're huge partners. And of course the ConnectABILITY, where we're from, and the care program, and knowing about all those resources. Hopefully this transition series has given some of that information. So now Lindsay.
So I'm going to talk a little bit about the role of CCAC in the aging process and how we work collaboratively with our developmental sector, and then what resources we have available to add to the resources that exist with the developmental sector as well. So I think we talked a little bit last time about the type of services that CCAC offers, so they're listed here. A big one, a couple of big ones, but with aging, sort of going back to what Andrew was talking about in terms of maybe in group homes or family homes where there isn't modification, there hasn't been modification, any grab bars, rails, all those sorts of things. Our CCACOTs, our occupational therapists, are able to do those home safety assessments, do mobility assessments, seek out appropriate funding for those resources, trial out resources. So they're really a really integral part to keeping people at home longer as they age. Similarly, our PSWs, our personal support workers, who as people age or with disabilities need help completing personal care, bathing, dressing, feeding, transferring. We're able to provide supports with that. And also, as we age, we have access to some additional resources that aren't listed here. We have nurse specialists who are specialized in dementia that often work closely with us, with care coordinators, to go out and address issues of dementia and behaviors in the home, as well as pharmacy. We also have pharmacists who can support medication reconciliations, work with the nurse specialists, work with the care coordinators, and work with the doctors to really do some solid in-home investigations. When we speak about aging, certainly one of the biggest points is that CCAC is the centralized access point for long-term care in the province. So yes, similarly as we would make a care plan at any age, we're involved in making care plans as we look on how to support people as they age or as they progress to long-term care. So your CCAC care coordinator would be responsible for helping you, your family member, your client to complete, for instance, if they were doing that, a long-term care application. We also do capacity evaluations to determine if someone can make a decision for themselves about where they live going forward. So with long-term care specifically, there's a couple different facets of it. So we do temporary stays, short stay respite within long-term care, which is 90 days in a 12-month period, where an individual could be admitted to long-term care to provide respite support to the family. Typically, these are individuals who are currently waiting for long-term care. There's also convalescent care, which refers to when people are, it's similar to kind of a rehab step down from when they've had, say, a surgery, a fall, something like that, to prepare them in a supportive way to return to their home and community. And then, of course, there's the traditional, what everyone I think thinks of, which is the long stay. So this is the basic eligibility for long-term care in the province. I really want to emphasize the third point down, which is that the individual have healthcare needs that cannot be met in with any combination of caregiving in the home or the community. So I think this is really important because often, and I think Angie alluded to it, when things become challenging at home and with increased medical and physical issues, oftentimes I think people's minds flip directly to long-term care. And I think we have a lot of resources to really work to keep people in the community, support in the community. Is this cutting in and out? No, it's just me hearing it? Okay. So certainly under the age of 65, we're striving to keep people in their own homes. Long-term care is a wonderful resource, and it's very supportive to a lot of people. For a lot of our younger developmental clients, for certain ones, it might not be the most appropriate resource. So we'll work to try and find a good solution, a good match. And I'll go into some of the ways that we do that. And also that the individual have healthcare needs that can be met in a long-term care home. So I guess one of the big questions is when people with developmental disabilities are going to long-term care, that's the decision and that's where we land, or are already in long-term care, what is it we can do as two sectors to support, to best support those individuals? So there's,
in the photo I just noticed something in this photo that sparked a memory of a situation. From your perspective in DS, can you see things that might be difficult in a long-term care environment for someone with developmental disabilities, even identified in this photo? Yeah. Exactly. Yeah. There's a curtain.
And just repeat the stuff that's
Oh, sorry.
That's okay. Just go back.
So what the audience said back was shared room. And Pam can also add to that because there are many triggers in long-term care that may not be the right environment, or it may be a perfect environment, but just to keep that piece in mind.
And I guess with that, I'm not sure if everyone knows, but when you're applying to long-term care, for the most part, you have a choice between basic, semi-private, and private living, which is typically 4 people to a room, 2 people sharing in some way, or private on your own. And ODSP covers your basic accommodation, so your typical 4-person in one room. So one of the big supports that we have is DSTO, Behavioral Supports Ontario, and they provide support in the long-term care home, for people with dementia, mental illness, addictions, other behaviors like that. We also have in Toronto transitional behavioral support units at at Daycrest. It's a 23-bed unit. People that are experiencing behaviors that are hard to manage at home with secondary to dementia can go into this transitional unit. The caveat of that being that really everything in the community really needs to have been exhausted beforehand. One of those things, and we don't have it listed here, is something called CAST, which is centralized access senior specialty beds in the hospital. So one of those connections would be the CAMH Psychogeriatric program. So we really want to see that we've tried a lot of things in the community, and as well that the individual have dementia. There's a community outreach version called Community Behavioral Support Outreach Team, and these are behavioral therapists that will come to the individual's home. So they have to be in the community and provide behavioral assessment, behavioral support, and work with families, again, to keep people at home. And if you have questions after, I can go into more detail if you want.
So does everyone know about the original geriatric programs? Who has heard about these programs? Yeah, quite a few people. So these are some resources, really good resources to use. There are regional geriatric programs across Ontario. And this means that we have access to healthcare professionals that have the expertise in terms of seniors and seniors with conditions like dementia. Remember, dementia is an umbrella term. So there are many different causes of dementia, Alzheimer's being one of them, for example. So even understanding that piece, we can use specialists from geriatric programs and work together, collaborate together with those programs to either help aging in place or also figure out long-term care, how can we best collaborate to form partnerships that will have safer outcomes. And that's important to both our sectors. And that's why we're really glad that people from long-term care and the CCAC are here today. And they're representing and showing that they're going above and beyond really to collaborate with us. Because I also see that sometimes we can have a negative perspective, and that may come from us not understanding each other's scopes and what we do.
And I just want to add to that, we're talking a lot about, obviously, long-term care and aging, but that the CCAC and the resources that the CCAC has, it's very important to connect with the coordinator, problem solve with the coordinator, because we do have a lot of options and resources we can pull together before we need to necessarily look at long-term care. So just to kind of make a caveat to that age isn't necessarily something that precludes you to go into long-term care. Just because you're an older adult, you don't have to go to long-term care, and that we do have a wealth of resources that can support you in the community.
So DD and disaster planning, we got a lot on this already today, talking about the importance, and Sue and Peter did an amazing job at talking about it. But there's some resources listed here, and we can also go at this topic from the perspective of community care resources. So Lindsay will talk about that piece, but for the DD side of things, we are catching up in terms of knowing how to even talk to someone who is dying and has a developmental disability, how to even tell them that they're dying. That we know, we've already talked about it today, that that's extremely difficult and you may not have the tools or the expertise to communicate appropriately and support the person with developmental disability who's facing palliative care.
So if we're at a point where we're discussing palliative care, the Toronto Central CCAC has a very robust palliative care program. Is everyone familiar with what palliative care is? Before we just use that word. Okay. So at the bottom you'll see these resources, and one of the big ones here is the Speak Up campaign, which is it has workbooks for doing advanced care planning. Very easy to work through, simple to work through, which they're really encouraging. The Speak Up campaign is about encouraging people to really take control of this and do advanced care planning for themselves. The Palliative Pain and Symptom Management Consultation Service works a lot with the Toronto Central CCAC about keeping people comfortable in their homes, minimizing the pain, controlling the symptoms so that people have a positive experience at home. And the Toronto Central CCAC, our two programs, palliative care and adult supportive care, work very closely together. Our clients, unfortunately, often transition from one to the other, well, from adult supportive care to palliative. And we work closely together to come up with a very meeting the client's needs, strong end-of-life care plan at home. But it is something that developmental disability specifically we haven't necessarily particularly targeted to date. So I think we're really looking forward to working with the developmental sector on this. But for palliative care, there's several choices, and it's about the individual having choice and deciding their end of life. So whether they're at home, whether they go into a palliative care unit, so that they have control over that.
Yeah, so there is a video on, and it's from the UK because I couldn't really find any great resources that are Canadian, but it talks about the difficulties of that topic, and then how are we able to modify the way we communicate about palliative care to developmental disabilities when there aren't a lot of resources that exist. But we do need to have the conversation. We need to be creative and have that conversation. And I think Sue also mentioned this morning that doctors and nurses, they probably would leave it up to someone who knows the person really well. So sometimes we expect that it should be the doctor or nurse that communicates that to the person with developmental disability, and they are expecting that, no, it's us. So someone needs to do it, because what little research there is, it's showing that we don't do very well, and there are people who had no idea that they were palliative and never had that conversation.